That's perfect. Amazing. Thank you so much, Dr. Najm.
All right. So we'll be talking for the next 35, 40 minutes about the ventricular switch procedure, which I believe is a paradigm shift in congenital heart surgery. And I tell you how I have evolved to do the first case in 2016, the index case, and then what happened after that. Before I start, I'm going to just give you just a background on who I am and um, what is my life history. So I was born in Riyadh and raised in Saudi Arabia, and I did well in school. I also was practicing Taekwondo, where I got actually a black belt, then 3 dan and now 5, and I'm a gold medal holder 3 years in a row in Saudi Arabia. This is the old days. Then I graduated in my class from King Saud University. Also, I did well then. This is my graduation in Saudi Arabia. Then I went to Canada where I spent 10 years. I did general surgery. I did cardiothoracic surgery as well as pediatric cardiothoracic surgery in sick children in Toronto. And I did also a Master's of Science in Cardiovascular Sciences during that time. After that, I came back to Saudi and I was quite busy. I was doing 450 to 500 open heart surgeries per year for almost 15 or 16 years. I became also the president of Saudi Heart Association. I became also the president of Saudi Taekwondo Federation. And then also I had relations with the American College of Cardiology, where I became also a chapter governor. And that was actually one of the first chapters that was started by the American College of Cardiology then. This is when I was in the president of Saudi Heart Association with the Minister of Health and our honorary president, Prince Sultan. Subsequent, and this is with the late king when I was doing a conjoined twin separation, and then after that I did actually during the same episodes I did actually cabbage on their father who was standing in between. Then subsequent to that, I was recruited by the Cleveland Clinic in 2015 or 16 when I came in actually January. And I changed the rank from 45 to 6. I tripled the volume at the Cleveland Clinic, and we have the best outcome of congenital heart surgery. And I have a patent that is on a valve that would be growing. So this is what we've done. And most importantly, it's not only that the volume has gotten better, but also we have the best mortality in congenital heart surgery, which is around 1.1%. Then I became also a trustee of the American College of Cardiology, was the only surgeon among all the cardiologists at the ACC. And last year, I received the Great Arab Minds Award that was given to me by Sheikh Mohammed bin Rashid Al Maktoum from Dubai for the innovations that I have done, and partly because also the fetal surgery that I'm going to share with you towards the end of this talk. So let's start with this functionally univentricular heart and why people call it functionally univentricular heart. Not because all the patients have one ventricle. No, but some patients will have actually two ventricles, but they are not amenable to septation. And I have actually put in some of these on red. Double inlet left ventricle. Now we know that we can septate them. Unbalanced AV canals, heterotaxy, hypoplastic left heart syndrome, but moderately hypoplastic left heart, not the aortic atresia, mitral atresia, and straddling AV valves. These are considered unseptatable hearts before, hearts with ventricular imbalance and with complex circulatory pattern. And this is one of the publications by Richard Jonas, who is a very senior known surgeon from Boston then. And this is the title is Fontan septation, Fontan or septation, when I abandon septation in complex lesion with two ventricles. So these are the lesions that even if there are two ventricles, you would abandon this and give them a single ventricle physiology. Now, why is that? Because the mortality of the single ventricle is low. The mortality for a modified Fontan, when initially it was made, was 30, came down to less than 2%, and still it is low. And the current preference of most centers is to do obviously a staged Fontan. However, it is estimated there is 1,000 Fontans per year. 1/3 of them will require surgical intervention, 2/3 catheter intervention, as well as they continuously need have a decreased ventricular function and exercise capacity. And this is how they look 10 or 15 years later. However, this is not a long-standing physiology because of the venous hypertension that happens and accompanied by Fontans. And that's why sometimes I label or I talk about this talk about the forgotten LV leading to a single ventricle palliation, which is not really perfect. And the more we follow them, they almost all fail. The problem is that's how they fail. They fail, first of all, the ones with heterotaxy and with common AVSTs, they are the worst ones. Once you have a common AVST, they fail miserably because of the volume overload, which happens quite frequently with all the patients with single ventricle because of the collateral flow. They get volume overloaded, they get AV valve regurgitation. And once they start failing, they fail with multi-organ failure. So it's not only that they fail with heart failure, they fail, the liver becomes cirrhotic, the kidney becomes dysfunctional, they've got plastic bronchitis, they've got protein-losing enteropathy. The issue used to be, which is kind of not a correct depiction, when people say, well, yeah, it's a two ventricle, single ventricle. So there are two ventricles, they should be better than a single ventricle, which actually is not true. So even if you have two ventricle heart that is routed to a single ventricle, it's the same as a heart with single ventricle. And the reason why the problem is not because of the ventricular function or ventricular output. It is because of the chronic venous congestion that happens in single ventricle with the Fontan not having a pump on the right side. So my proposal is the following. Would you rather have a single ventricle physiology like the one on the left, or would you rather have a physiology that is similar to the congenitally corrected transposition, which is what? Which is the left ventricle pumps to the lungs and the right ventricle pumps to the body. So if you cannot harness or recruit the left ventricle for the left system or for the systemic, then don't abandon that heart. Don't abandon that left ventricle. Use it. And that was my publication when we put these patients together. This is the index case. 10-year-old complex congenital heart that has total anomalous pulmonary venous return, pulmonary atresia, demalposed vessels, aorta to the demalposed aorta, multiple aorta pulmonary collaterals, and a common AVSD. So he's had multiple operations before. And if you look at the view on your right side, there's a 3D printed heart, and I use this quite frequently, and you probably see this in the background of my camera. I have a whole cabinet with a lot of printed hearts, 3D printed physical hearts, and I do this. We do also the virtual reality now that I could actually get in the heart without in the virtual reality. But going back to the 3D printed hearts, you see the aorta and the right ventricle, as you see here, are coming out of the right ventricle. Aorta and the pulmonary artery coming out of the right ventricle. However, because this left ventricle was so far from the aorta, and the venous connection were so complex that the previous surgeons decided that they will not actually septate the heart. And this was the case of a 10-year-old that was, his saturation was 55% when he was presented to me. And the idea is like, I remember one of the senior cardiologists came by and said, "Honey, can you do something? This kid is going to die in 6 months." This was in 2016. And if we don't do anything to him, I mean, obviously the usual would be, oh, let's upgrade his RV to PA conduit. And to me, it didn't make sense because there was some stenosis. As you see here, there is a stent in the RV to PA conduit. It didn't make sense because the problem is mixing. The patient is receiving systemic uh, venous return going to the aorta from the right ventricle. And that's why he's blue, not because there's an inadequate pulmonary blood flow. And this is where the idea came to me is, you know what? I'm going to actually have him pump from his left ventricle to the lungs rather than from right ventricle to the lungs. And because the the pulmonary venous return, and I need to do an atrial conversion. And I'll tell you a little more about this so you can understand what it means that. And this is what this 3D printed heart is, and how I would look at it and how I've seen it. And that's why I think 3D printed heart and complex heart reconstruction is really important. And I like it together with the virtual reality because I like to put the heart on my desk and keep going back and forth to it until I find out the best solution for reconstructing this heart in a two ventricle circulation. By the way, so let me show you. This is the picture on the left was this guy, Ethan, 10 years old. See how thin he was? His saturation was 55. See how blue? He was on oxygen. He couldn't even walk. And if you see here on your right side, I don't think you can hear this. This is him a year later. By the way, do you hear the audio or you don't? I'm just asking.
No, I don't think we can hear the audio.
Yeah, maybe I didn't share with audio. But anyway, so that's the video. That's how he is. This is his when he was on TV. He was told, his mother was told that he's never going to survive, and this is where he is. He's playing basketball. So, ventricular switch is a concept rather than a defined procedure. It's a collection of procedures. Ultimately, the right ventricle becomes the systemic ventricle. Could be planned from birth, depends on the complexity of the lesion. And you may have to do, if the left ventricle is moderately hypoplastic, you can do 1.5 ventricle repair. The whole idea of this is that you get a lower atrial pressure, systemic atrial pressure, so you don't have the venous congestion that you get with the Fontan. So now we know there's an atrial switch procedure, there's an arterial switch procedure, there's a double switch, which is a combination of the top two surgeries. But now this is the ventricular switch procedure where the right ventricle becomes the systemic ventricle. Now, a lot of people could say, well, oh, yeah, but this is like a CCTGA, it's a physiological repair. However, the physiological repair that was given to the VSD closure in congenitally corrected transposition is a completely different operation. So we're not talking about a patient with a congenitally corrected transposition who's got a double discordance, so right atrium to left ventricle to the pulmonary artery, and then left atrium to right ventricle to aorta. This is the double discordance. So when they have a VSD, it used to be instead of doing a double switch, they just close the VSD and keep the right ventricle pumping to the systemic circulation. This is principally is the same concept, but it's not the same operation. And that's why it's a misnomer. And I would say this is what I was talking about. VSD closure and CCTGA, they call this as physiological repair. However, these operations are much more complex. If you add to this a VSD with an LV to PA conduit, the AVSD with LV to PA conduit, AVSD with total anomalous permevenous return, and an LV to PA conduit, which is not unusual in all these congenital in these ventricular switches. VSD or AVSD with atrial switch, which is not uncommon. AVSD with TAPVR, moderately hypoplastic left ventricle, and also a lot of other operations. So this is not really a physiological. They are not the same risk. They are a different operation with a different outcome, and that's why it should be called the ventricular switch procedure and not a physiological repair. And the idea is, as I was saying, LV can be harnessed for use in the subpulmonary circulation when it cannot be committed to the aorta. So the LV cannot be committed to the aorta. You keep it to the lungs and leave the RV for the systemic circulation. Conversion to a congenitally corrected transposition physiology is preferable to a Fontan. Why? Because when CCTGA physiology fails, it is right ventricular failure. And when it is, it's like heart failure, which can be managed by heart failure medications, assist devices, or transplantation. So it doesn't yield a complex multi-organ complication like what we see in the Fontan circulation. How do we know that? How does the right ventricle behave in the future? Because the right ventricle is not made to become the systemic. This is data from the CHSS comparing atrial switches with arterial switches up to 30 years. You look at it on the left side. It's not actually much different. Their survival. So that right ventricle, those patients who had atrial switch, they still had the systemic right ventricle being the systemic ventricle. So they're not so bad compared to the arterial switch. And if you look at those who had a physiological repair of a congenitally corrected transposition or anatomical repair, again, the difference is not even statistically significant. They still behave well way into the 20s and 30s. And that's why it's much better than having a single ventricle. These are some of the lesions that are suitable. And the idea really for the ventricular switch is to understand what the concept is and then do the right operation for that patient, because they can come in with all the complex different lesions that are not at the bottom, at the end, they're not amenable to a single, to a biventricular with an LV-based biventricular conversion. So we shouldn't be putting them back into a single ventricle. So what I've created here, in some, at least through my experience and the ventricular switches, I've created some of the areas that have actually caused morbidities post-op, and I think it's really important, since it's a newer procedure, we need to refine it and get it to really the best people. So you need normal ventricular function. If you've got a bad ventricle, and this is the problem with it, I have to deal with failed Fontans who are having ventricular dysfunction, and that's why we get really burned with those patients with bad ventricles. RV end diastolic pressure should be less than 15, so you should have a good right ventricle so it functions well. RV end diastolic volume more than 50 mLs per meter square, so you can't actually convert to a right ventricle based biventricular repair if the right ventricle is small. LV end diastolic volume of 40 meter per square. And for two ventricle repair, and if you're doing for a 1.5 ventricle repair, then you need at least 25 mLs. You need to have less than moderate AV valve regurgitation, because we've learned also, because of the pressure loading, if we have a lot of AV valve regurg, you underestimate the ventricular function, and once you fix the valve, you can have detrimental effect on the ventricular function. Unobstructed pulmonary return, normal liver function and normal kidney function, and absence of left ventricular endocardial fibroelastosis. So these are kind of general ideas. The procedures that needed to be done for a ventricular switch procedure can be any combination of these. All congenital surgeons do them. Arterial switch, bidirectional cable permission, AVSDs, atrial conversion, or atrial switch, or a hemi-mustard. Because many occasions, if you have a moderately hypoplastic left ventricle, you're going to actually put the IVC flow into the left moderately hypoplastic left ventricle and do a bidirectional gland. And I'll give you an example of that. So let's go through some of the examples. This is a ventricular switch in a Schoen's complex. So the patient was born with a moderately hypoplastic left ventricle. So you're not sure that left ventricle is going to be amenable to a full biventricular conversion. So we do a Norwood procedure right from the outset. So the classic Norwood, you do a DKS, as you see, and you do a Sano, which is right ventricle to the pulmonary artery. And then they pass the neonatal period. Then they can come back at 7 months, like here, and then we take down the Sano, and then take the aorta, as you see here, take it away. So keep the PA connected to the aorta and to the arch. So now this is going to become your systemic outflow. So right ventricle, pulmonary artery, or the neo aorta, and we close that original aorta, which is usually typically a small aorta, and then do an arterial switch. So we take the arteries from the old aorta, put it into the new. Now this becomes the neo aorta because you got RV, you got aorta with the coronary arteries, and it's going into the arch. And then you finish that out with a hemi-mustard, which means that the IVC is routed into the mitral valve. And this patient had a VSD, we closed the VSD. And finally, obviously, finish that out with a bidirectional gland. So SVC comes back to the right pulmonary artery, IVC goes to the mitral valve ejects through the original aorta, which is reconstructed. Now it becomes the neopulmonary artery, and it ejects into the branch PAs. And obviously, because of the hemi-mustard, the pulmonary veins drain back into the tricuspid valve, into the RV, into the pulmonary artery, which is now the neo aorta. So now it's a lot of surgery. However, you've got a two ventricle circulation rather than a single ventricle circulation. And there are a few others. This is another complex case who had a bilateral SVCs and hepatic veins separate from the IVC demalposed aorta. This was an adult who was clubbed and cyanosed and had a polycythemic stroke and needed to have this because his saturations were low. And I did an AVSD septation, as you would see here. So started off, this is his anatomy, LV, RV, his aorta comes out of the right ventricle, and he had total anomalous pulmonary venous drainage to the left SVC. So I ended up actually taking his pulmonary veins, putting it into the right atrium, septating the right ventricle from left ventricle, and then this is the pulmonary vein that was hooked up to the right atrium, and then doing an atrial conversion where the IVC hepatic veins were routed to the left ventricle with this atrial conversion. The left SVC stayed as it is. I translocated the right SVC to the left SVC. So now all the venous return is coming back to the left ventricle, and the pulmonary venous return is going to the right ventricle. And then I finished that up with an LV to PA conduit, and he came out with saturations of 99%. Double out of right ventricle with a remote VSD. This is another lesion that typically surgeons say, well, this is a remote VSD. You cannot route the left ventricle to the aorta, so let's just do a single ventricle repair, which obviously is not the good scenario because you got two nice ventricles with good function, and why would you actually leave it at that? So the surgery for this is cut the pulmonary artery, close the VSD, and now the RV is connected to the aorta. The PA is divided from here, and then it's very simple. Do an atrial switch with a hemi-mustard, and then that's what the atrial switch is. So now the venous return goes to the mitral valve and the left ventricle. Then finish that up with an LV to PA conduit. So you've got an atrial switch, VSD closure, and LV to PA conduit. You got a two ventricle circulation. This kid is doing so well because we did him very early in life, and he's doing so well. Now he's 3.5 years of age. This is basically a kind of a video depiction of this operation. This is how the original thing, and then basically close the VSD, do an atrial switch, do an LV to PA conduit, and now what you have is you have a two ventricle circulation. Another operation that also, this is an 11 months old heterotaxy with dextrocardia, double outlet right ventricle, pulmonary atresia, and a common AVSD, and a left superior vena cava. So these are complex cases. However, so the initial operation, because he was obviously had pulmonary atresia, we needed to do a permanent sort of pulmonary flow. So we did a right ventricle to pulmonary artery conduit using a 5 mm reinforced cortex. Patient did well. And then this is what the original operation. So it's dextrocardia, LSVC, IVC is on the left side, moderately hypoplastic left ventricle, and a good right ventricle with a aorta attached to the right ventricle. So when we brought him back, I took down that Sano shunt or the RV2PA conduit, then septated the AVSD on the inside. Now knowing that the left ventricle is small, so what we need to do is get the IVC to the left ventricle, and that's what we did with the atrial conversion or hemi-mustard. So the IVC is now draining into the left ventricle, and the left SVC is draining directly to the PA. So now you separated the venous structures. And then finally, an LV to PA conduit finishes up. So the IVC will go through the AV valve into this LV PA conduit into the main pulmonary artery, and the kid is also doing well. The venous return, the pulmonary venous return, which is here, comes back to the right ventricle, goes out of the aorta. This is the actual operation. Let me just play it quickly. So this is the Sano shunt that has been put in the newborn period. Now just dividing opening the right atrium. So this is basically the head of the baby is to the left. Now because obviously you would expect that there is, I did that. Now this is the ventriculotomy. And now I'm doing the divisions of the AVSD. I'm standing on the left side of the patient. This is the common AV valve. So the anterior valve is this one, is the right ventricle. And the posterior valve is the left ventricle. But I have to divide this. The IVC, as you see, is on the right side here. The SVC is on the left side here, and the head to the left of the surgeon. So this is the surgeon's view if you are standing on the right side. However, I was obviously operating from the left side. So what I do in the common AVSD, and that is my technique, is I divide both superior and inferior bridging leaflets every time because I can see better the VSD. So this is a patch that I'm closing the VSD with. So now the VSD is closed. Just trying to run this fast so we can get to see other cases. Now, as you see the marks here, now I'm doing the hemi mustard, which is basically using a autologous pericardium to divert the IVC into the left ventricle. This is it here. So this is it now. It's diverted. As you see, this is the hemi mustard, where the IVC is going to the left side. This is now doing the LV to PA conduit and the left SVC into the left pulmonary artery. Basically a left-sided bidirectional gland. And finally, the LV to PA that I have done with a Contegra graft. This is the proximal end, and this is after coming off bypass. So this is one of the interesting cases, one of the adult cases that I've done actually with the Fontan conversion. You see on the left side, this is the preoperative screen. Pressure, his Fontan pressure was 41. You can see why they get actually venous complication. This is his Fontan, this is his after his BIV conversion. His CVP was 18 and his LAP is 14. So you can imagine how much they get better when you drop the CVP of a single ventricle from 41 down to 18. This is how sometimes they look, these LV to PA conduits. And I have done them in different ways. This is kind of a homemade conduit that I put in a valve inside the conduit so I can have as long a conduit as I want. And I implant a tissue valve inside it. So it is important to understand that if we will to do something like that, you really want to do this in somebody who has not failed the Fontan stage, because they fail it, then the results are not good. So it's much better to do Fontan conversion in patients who are still in good shape. And that's the problem, because a lot of the cardiologists continue to follow these Fontans until they fail before they subject them to a repair. So this is basically some summary of the cases that I have done, 17 of them. And this is their average age, 5.2. Prior numbers were prior surgeries anywhere between no surgeries to 5 surgeries. And this is their follow-up time. And so I've had 10 patients. I had 10 patients who had unroutable LV to aortic outflow with normal size LV. So these are patients who've had 10 of them had a normal size ventricle, left ventricle. They ended up with a full septation by V. 7 of them had moderately hypoplastic left ventricle and needed to have a bidirectional gland in addition to their conversion. And these are the different operations that I have done. We've had no early mortalities in the initial. We've had 3 late mortalities, as I was saying. These ones with complex lesions with poor ventricles, poor levers. So the reality is these patients have to be converted before they fail their Fontan. This is the survival in 5 years. And some of the surgical pairs that we've learned really have to optimize the patient before surgery. This is a big operation. You need to do it. Make sure that the heart failure is managed, the kidneys are optimized, all that stuff has to be managed very well. And then you need to use certain techniques to simplify some of the intracardiac conversions, like a translocation of one SVC to the other, like what I have done, like creating an innominate vein, which I have shown you in the drawing, and I've done it actually quite a few times. We're going to publish our series on this one very soon. I've done probably around 20 of those translocation, and they are much in different types. So when we have bilateral SVCs, I do not like to do bilateral bidirectional gland. I like to do a translocation of one SVC to the other, and I do one bidirectional gland. You need to we need to optimize the postoperative AV valve function, and that's why I learned also that we need to do a preemptive AV valve stabilization with an annuloplasty, even though that they don't always leak. When we pressurize our right ventricle, the dimensions change, the septum changes, and then you start getting possible AV valve regurgitation. The RV function should be normal, and we should always consider the ventricular switch in younger patients prior to dysfunction and for TAN failure. Some other takeaways: ventricular switch is really a versatile approach to achieve biventricular circulation in a range of complex congenital lesions. We demonstrate the improvement in oxygen saturation, the CVP drops down, the outcomes are acceptable, but long-term outcomes needed still to see how they do at a later stage. And listeners, we learned that we really need to stabilize the AV valve competency, and we have to have a normal ventricular function. And also, we started doing a band between the outflow of the left ventricle and the bidirectional gland. So the takeaways: widen your horizons when facing a complex lesion. All cases are multiple redos. Hemostasis Hemostasis during opening is important. It's not, as I always say, these redos, hemostasis is during opening and not during closure. 3D printing is important. Plan the sequence of surgery with your colleagues. Brief your team before. Otherwise, you're the only one. So they have to understand what are you doing. The single ventricle will pump two cardiac outputs. So if you have a patient who is being routed into a single ventricle, which means that the two ventricles are pumping one cardiac output, now you septate, you expect each ventricle to pump one cardiac output. So you've got double. Whatever that muscle mass is going to double, pump one cardiac output to the lungs and one cardiac output to the body. And you know what? It does. And we know we've got the proof of concept for that. With that, I will stop and I will answer any questions before we get into the fetal surgery.
Perfect. Thank you so much, Dr. Najm. It was a brilliant talk, and it was very nicely summarized about the different use cases and, like you said, the concept as opposed to one specific procedure. And I think that's something that a lot of people struggled to grasp in the beginning as well when you described it. We did have a question so far, and it's been, what's your experience been in terms of training others in the ventricular switch procedure?
Well, I mean, the whole idea of the ventricular switch is more an understanding of what the principles are. The reality is, all the bits and pieces of the procedure is done by all congenital surgeons. I mean, every congenital surgeon does an arterial switch, does an AVSD repair, does a bidirectional gland, does an LVTPA conduit. They do it in every other. The concept is the concept of actually thinking out of the box, saying, you know what, I'm not going to ignore that left ventricle, even though that I cannot make it to pump to the body. I would want to do this, and that's how it is. It's an introduction to these complex lesions. And I've obviously had surgeons who came and said, oh, you can always baffle them and so on. Reality is you cannot. And I say, well, wait for the next case to come, because you will get a case with multiple redos that if you're going to actually do something to the kid, is the only operation will be a ventricular switch. The reality is, if it is actually, if you're gonna do this in every other patient, we'll be doing like 50 cases, 60 cases, and so on. It's not. It's meant to be a solution for the no solution patients.
So kind of the in-between borderline, the patients where you don't want to kind of commit to one pathway. Those patients, which you say are the ideal.
So if you want to ask more questions, I'll be happy. If you want to pivot into the fetal surgery, I'll be happy.
Sure. I think there's one more question from Dr. Adrian Christian. Where exactly do you incise the MLV for the conduit to the PA? Do you excise tissue? And he's got two more follow-ups as part of it as well.
Good question.
Do you
First
get
of all, yeah, you have to know obviously that the papillary muscles of the mitral valve are arising from the free wall of the ventricle. We know that, okay? They're not like the papillary muscles who arise from the septum, like the tricuspid valve. So you need to cut in front. So my landmark usually somewhere uh, anterior and leftward or away from the LAD, but it's still anterior, so you're still away from the papillary muscles. And sometimes what I do is I go through the inside of the ventricle, locate the papillary muscles, and then I actually literally poke an instrument from the inside to the outside because I know for sure, and obviously I would look outside, there are no coronary arteries, and make sure, and then I make my incision. And you really don't need a lot of muscle resection. And you can go close to the apex of the left ventricle where you know that it's going to be safe because you don't want to be also cutting close to the base of the heart where it becomes thick.
perfect? And as part of it, he's also asked, do you get arrhythmias originating in the LV? And have you had the chance to study the effects of the LV incision on its function?
Yeah, good questions. Arrhythmias, no, because we do this all the time. I guess if we follow them for 20 or 30 years, like tetralogy fellow, they may have some arrhythmias, but I haven't seen early arrhythmias. Uh, Now, the other question was what?
Have you had the chance to study the effects of the LV incision on its function?
Yeah, no, we haven't, but most of them actually, if not all of them, have a very close to normal left ventricular function on follow-up. So I think the you see the thing is with the ventricular function is now this is a low pressure pump. So it pumps only to the lungs. So you're not concerned so much about it because most of them have been uh, pumping systemic for all their life because they're usually having a VSD. That's why. So, and now you make them pump only to the lungs. So you've got plenty of function there to sustain the lung circulation.
And he has a question as well. Have you thought of a dunk procedure like for a Norwood as part?
Yeah, actually, the very first the operation that I showed you, I dunked the proximal sano. However, these repairs are not done in babies, so you need to do a formal ventriculotomy and an RV2P conduit. But if you do something in the newborn period, yes, you can dunk it.
And how do you monitor and optimize ventricular function in the immediate post-op period?
So I leave an LA line almost all the time. And I like to do this because the ICU will have, it's much better for monitoring post op. And the usual CVP. So the best thing is your LA line to measure your ventricular function.
Amazing. And I think we have one I guess, very important question about the concept itself is how much, to your knowledge, how do you think this procedure is going to get acceptance worldwide?
Um, well, it's going to go on history as being an operation for complex lesions. I don't think there will be hundreds of it being done, in all honesty. And it's not going to be like the arterial switch. Okay. However, uh, it is a concept that people, I mean, the Boston Children has already published on this, by the way. And obviously, every publication on ventricular switches, I end up getting to review because obviously I created this concept. So busy programs are going to see them and they're going to start doing them. And I would think average programs will not uh, will not embark on doing a biventricular conversion. The reason why is that it's complex and you need to do a lot of surgery. However, advanced program will do them and will get good results with them.
Okay. And one last question, I think, before we can proceed to the fetal section, if that's all right. Uh, the question that I had as well, in DORV with remote VSD, is there some kind of quantifiable threshold where you would go for a ventricular switch as opposed to a biventricular repair?
Yeah, I mean, the first thing typically that these kids will have two good sized ventricles. So size and function is not an issue. That's one. Two, you need to do the 3D printed out. Let me actually switch my computer this way. You see this cabinet behind me? This is all 3D printed hearts. So what I'm saying is, uh, you need to look at the 3D print and see whether you can route the LV to the aorta. Now, if you have a remote VSD, you may route it, but then you get a obstruction to the tricuspid valve because you're going to have to put this across to the aorta. One, or you get an obstruction of the right ventricular outflow tract. Again, two. So, or you need to enlarge the VSD and you may get heart block. So all this stuff that happens. So what you need is to decide if that's the case that I've done, and the kid is doing so well. He was in massive heart failure because he had restricted pulmonary blood flow. And the problem with the DORVs, because of the streaming, they blew because they are in heart failure and they're blue. So they're not they've got pulmonary overcirculation, but at the same time they're blue because the streaming, the systemic venous return goes to the aorta. And that's why, and the VSD that comes back from the left ventricle gets pumped into the PA. So that's why they're blue and in heart failure. So you just need to know whether you cannot, if you cannot route it, then that's what you do. You do a ventricular switch.
Perfect. Thank you so much, Dr. Najm, for answering all the questions. I think it's really helped us all grasp the concept of the procedure, and hopefully by the time we're all operating surgeons, we might get a chance to perform one maybe.
Well, keep it in mind for sure. It's not science fiction, it's reality.